Hey, welcome to New York, everybody. It's good to see you. It's been a week since we said hello. So my name is Dr. Krishnan. I'm here at Mount Sinai, and we're with our vascular team here doing another interesting case, hopefully, in which you can get some tips and tricks that will help your practice. Let me introduce my team to you. To my left is Ray Lascano, our endovascular nurse practitioner. To my right is our interventional fellow, Dr. Osman Jaffer, who's going to be graduating in a little bit. And then behind us is Marichu Malloy, our interventional nurse for endovascular procedures. And I guess right next to her is our lead tech, one of our lead techs, Habib. And we have a very interesting case here that we're going to present. I've already kind of started on it because it's a longish case. And Dr. Jaffer is going to present the case for you.
Sure. Keep it slow. Great. I get the next slide here. So it's a 73-year-old male. He's a history of hypertension, hyperlipidemia, HFpEF, presenting to us with lifestyle-limited claudication, Rutherford category 3. Really, over the past few months, his pain has progressed. He's now having pain with minimal movement bilaterally. His exam, he's got muscular hair loss, diminished pulses, and ischemic changes around the first and second digits. ABIs are 0.45 and 0.66. And his duplex essentially shows an SFA CTO. He recently underwent a right-sided intervention with Zilver and supera stenting. He's basically now presented for a left-sided SFA intervention. On the angiogram, he's got some disease in the proximal SFA.
Oh yeah, go ahead, put it on.
And then
play the angiogram.
Yeah, we'll play it right here. Let's see here.
That was it. Mm-hmm.
All right, let's see. That's it.
That was it.
That's right.
What you just had.
That's it.
No, minus. Oh, okay. I see. You're playing this one. Go ahead.
So you can see right in the mid, kind of approximately the mid SFA, he's got a pretty long segment CTO. We'll show you the next picture here. And what you'll see is that really a lot of collaterals coming from the profunda and reconstituting down into the pop with the perineal going all the way down to the foot.
No, it's right there. It's still in the holder.
So very, very long, very challenging case. Here you can see a little bit in the pop, and then really a perineal, TP trunk perineal going all the way down into the foot over here. Our foot picture here.
I can't hear anything.
So you can see down in the foot, you have both the AT and the PT form off the perineal, and you can see that this particular patient has really just single vessel runoff to the foot with an occluded SFA. And really not much robust collaterals to the pop until Dr. Kapoor has joined us. Hi, Dr. Kapoor.
Hello, sir.
And so we are going to go ahead and do this with this case. I mean, we'll see whether we can get this down. So what we decided to do was go with an 035, an 014, what is it called, catheter into this SFA. And you can saw there that we broke the cap. So now I'm going to switch to a glide wire, or you can try an 018 command wire if you'd like. Why don't you give us an 014 command wire? And I just want to take a picture here to make sure that we're not inside that collateral, which I don't think we are. We'll see here, or maybe we are in the collateral. Let's see. Doesn't look like it there. I don't know. It's hard to tell. Maybe in the collateral, may not be in the collateral, but we'll see. It seems to be flowing pretty smooth. So let's get the command wire and then take it from here and see what happens. So we got a hydro. So the choices of wire here are hydrophilic. And the bottom line, I think, at least with our logic, is very simple, Vishal. That we say to ourselves, well, are we going to get away without stenting this? And the reality is likely not. So we're going to go ahead and go forward with this, and maybe Marichu can man the phones for us if there's any sort of questions coming through. So the issue here is your long segment CTO, Vishal. You have a long segment hold for us there, which is across the pop, comes back with a small island of collateralization at the level of the pop, and then you have a long segment CTO, and then a perineal artery that starts to come. Wow. So what I'm going to do here is just try to loop the command, and then take the command down. and then have Ray just track that down. Track it down a little, Ray, if it goes or it won't go. It may or may not go.
So I think your thought process is to try to keep the dissection place as minimal as possible.
That's not where we want to go. That's definitely not where we want to go. So give me now a glide wire. So command wire was too flimsy, went where it wanted to go. So we'll try with the glide wire. And then we're going to go down with the glide wire. I just want to try to get the dissection plane down to the pop and then decide what we want to do. We have a low threshold of getting pedal access to come back up if we need to, and we will do that, and then we'll decide at this stage. Pull back a little, Ray. So we're going to pull back a little bit at this level. Yes?
Was revascularization, was surgical revascularization an issue? And would it be an option if you do not recanalize?
You know, the problem here is it's a claudicant. You're going to go all the way from this level to, you know, all the way below the knee. So I don't necessarily think a surgical revascularization is a good issue. It looks like we're perfed out here.
Yeah.
For sure. Pull back again, Ray. Yeah, this is not a situation where you want to be. Clearly, we're not in a good area. Okay. Ready, push right now.
What size sheet do you have and who makes it?
What size sheet do we have? We went with a 7 French. Go forward now, Ray. Let's see where that goes. We're in a 7 French sheath, and who's making the sheath right now is this is made by Terumo, which is a let's see, which is a sheet that's a destination sheet. Track it down, guys. Let's see where it goes here. That's good. Track now.
Is the command wire hydrophilic?
It is. Command wire is hydrophilic.
Who makes it?
Okay, push forward, please. So you can see for the audience at home, what we're doing is we're dissecting. I know we had perfed out, but I'm not too concerned about that. I'm just continuing forward, not stopping. Vishal and I don't normally stop anticoagulation.
Right.
And now you're going to see, we're going to now do a roadmap to see where we are. So what I did was I looped, and I know I have a large loop. We found another plane, and now we kind of have a target there that we want to go to, which is our island, which is not good. So Ray's going to track that down a little bit closer for me. And I'm going to try to shrink my loop here and then go forward. Go ahead, Ray. Which is fine. Go, Ray. So we're just going very, very slowly with the loop dissection technique here. There's a little bit of resistance. That's fine. Come down, Ray. Hold it right there for me. And this is sometimes the fibrous tissue that you deal with, which I'm okay with. Come down, Ray. Now I'm going to make my loop a little smaller. Probably going to go to another view here to get another better idea of how far or how close we are. Raise the table a little bit. Actually, this has to come down maybe a little bit.
Yeah.
Nope, that's too much. Okay, that's good. That's good right there.
What about?
Okay, inject. So now we're just going to see how close we are to our reconstitution zone, which is right there, and you can see there's a double, there's a little overlap here. So we're going to have to be very gentle here. Hopefully we're lucky. A little forward, Ray. Hopefully we're luckier than we are good. Vishal and I always say prefer to be lucky than good here.
No, but I think
Go forward, Ray.
concept is right. Just trying to avoid and make sure we land, get the island, of course. Salvage as many collaterals and not traumatize them or cause any trauma to the collateral, especially the geniculate and the pseudo collaterals, which will go
there. Now we're pushing off. You see to the side? Yeah. That's going to be an issue here. So yeah, we might have to get pedal access here, which we will in a second. Just want to see where we are for me to decide. It could mean, and again, like I said, it's not something that I'm not going to not stent, but I'm going to have Vishal just do a DSA for me here.
We're ready.
So, ready, inject?
Ready. Injecting.
So we're going to do a prolonged DSA, and we're going to see how far and how much of this segment is actually a viable segment. Looks like a lot of it is viable.
Yeah, I can see
so what we're going to do now is we're going to switch out of this wire. I'm probably going to pull this back and switch this wire out to something else. So let's see. I'm in that blind pouch there, it looks like, Vishal.
Yeah.
Let me just try to torque. All right, guys, give me a pedal access kit here. Let me do pedal. Or do you want to do re-entry? What do you want to do?
I was thinking if we plan, like we were talking about switching the wire, maybe we could go down with the Confiance or something.
Okay, give us a Confiance. Let's see whether we can get in.
We can pop through. If not, then of course you're right. Pedal access is the way to go.
Huh? So. Yeah, we have a confianza.
Yeah.
Yep. Yeah. Well, we just need a micropuncture kit.
Yeah. Just make sure the ultrasound. Thank you.
Give me another confianza. This is kind of messed up. So now we're switching to a 014 wire and trying to pop in. Give me a Connect 250T as well, too, please. And then we'll see. This wire tip is a little messed up for me, but we'll see whether we're lucky enough to pop in. And then, or do you want to do an outback into this and then go from there? We could do that too.
Yeah. We have a new confianza ready.
I think we're going to need one, yeah.
Yeah, we have it ready.
Give me a little die.
Yeah.
Okay, reasonable area.
Yeah. I think it looks good.
So we're having a lot of interference. We can hear somebody named Pedro talking. I don't know who Pedro is. I'm sure he's a wonderful person. Kind of in the way, a lot of interference with our discussion here that we're having. So I don't know who Pedro is. Just letting the AV team know we're having some crosstalk. Nope, we're definitely not in it.
You're not in the dissection plan.
That looks like a collateral, Vishal.
Yeah.
Hold on. So you can see there, my wire might have gotten into a collateral, so I'm going to check my status here by taking a picture. And if we're in a collateral, that's a good situation. If we're not, it looks like we are in a collateral. Yes, we are. So you can see I'm in that collateral into that little branch.
That's a good sign.
So that's a very good sign. See, just following. Let's do a road map for me.
No, you don't have to inject. Hold on.
Okay.
A little smart. Okay.
A little more. Yep, that's good right there.
And then smart mask. Okay, go.
Okay, don't move the legs, please. You can just step out for a second. Let me see what I can do this. So hopefully we'll pop in somewhere here. That's not it. Huh.
Interesting.
We're definitely in that collateral. Let me see if I can get into the other branch here.
Yeah, I was gonna say we can.
Yeah, we're definitely in the collateral. So we're in the collateral.
You want
so let me just make sure. Let me go to another view here.
Save that.
Save that there for me. Just press that button. Yep.
Yeah.
So yep.
You have the command, right?
Just a roadmap. Go.
Mm-hmm.
Is the concept of pedal access the same as contralateral injection of the coronary CTO? The answer to that, I would say, is no. It's definitely not the same as a coronary CTO contralateral injection. I think it's completely different than a contralateral CTO coronary injection. Just because I think the coronary CTO contralateral injection is used for you to be able to see the collateral and to see where you are. Here, the pedal access CTO is really completely a different situation.
I have a command.
And so therefore here we're using it to cross the lesion. This is messed up. Here we're using to cross the lesion and not necessarily for the coronary CTO situation. So yeah, no, to answer the question, no, it'll be a transcollateral coronary cross, maybe a better adjective to describe pedal access.
Another question, do you perform dissection re-entry too?
Well, that's exactly what we're trying to do here. We're trying to do dissection re-entry as we speak. So what I've done here is, so we did dissection, and now we're re-entering with an 014 wire into the island rather than extend the dissection plane down into the pop. So what we're doing now is we're into a collateral from above. So what I'm doing is I'm doing dual wire technique by anchoring my catheter in the collateral and then deciding whether I can flop the hydrophilic wire into the true lumen of the larger vessel that we want to go to. If not, we'll come from below. Just going to give a few minutes here, a good attempt, and then we decide. Again, as you can see here, the vessel is very diseased, so it's not a very difficult thing to understand that we're going to have to stent across the knee joint in this situation, and that's where the Supera stent is going to work out so well for us if we get in. Do you see my wire?
Not yet. No.
Let's come off roadmap here for a sec. It's fine.
I have 4 questions. Do you maintain a radiation limit for such cases?
We always keep a There it goes.
Yep, I see it.
We always keep an eye on the radiation for sure, but this room is very well equipped, and we have worked on long cases with minimal radiation, I would say, or not over radiating for sure. I mean, things can get messy can happen, but we have the radiation right on screen as well, so we do keep a track of it. And especially if not us, then Ray will help us, or Damien, or one of us will definitely gives us a nudge to make sure the radiation doesn't cross the limit. But
we're also on low fluoro here.
Correct.
So we will be on low fluoro.
About torque curve if you want.
Contrast do we anticipate to use?
The patient has been prepped and hydrated. The idea would be not to use too much contrast, obviously. So we'll try to keep our contrast load low.
Role of the knuckle technique?
You saw the knuckle technique here did not work well because we're trying to get through, and unfortunately did not seem to work. So now we're going to have to go pedal, which is what we're planning on doing.
Someone said, would IVUS help?
At this stage, no, IVUS will not help.
18.
Interesting.
Wow.
Okay.
Okay.
So we are going to go. Or we can do. You want to do a what is it called?
Ultrasound?
You want to do this one? Pioneer catheter.
If you want, yeah, we can try a Pioneer.
Yeah, give me a Pioneer
Let's
catheter.
try
Guys.
Pioneer,
Let's try
yeah.
a Pioneer.
The Pioneer re-entry.
What's going on? Okay. Which is which now?
This is the
Confianza?
command.
This is the
No, I
command.
changed.
Okay,
I gave
good.
you the torque on the command.
Okay.
I switched it.
Okay, so we're going to go with the Pioneer.
And this now you have the Confianza.
Is the Confianza?
Yeah, and this is the command. Yeah.
Okay, wonderful. Okay, good. Pull out the Confianza. Good. Wonderful. Huh?
Yes, please.
Yes, please.
Yeah, it's right there. You're right. I think we're hitting.
It's just we're hitting the cap right there.
Correct. See, again, collateral.
Mm-hmm. Mm-hmm.
I don't think we use it, right?
Walk this out.
Mm-hmm.
So what we're doing now is we're just going to go ahead and take a Pioneer catheter, which has IVUS capability, to go ahead and try to enter this little lumen that we have in below.
You should have the wire.
So the Pioneer catheter has IVUS, and I think these are you could do a pedal access. In the meantime, I'm going to have Vishal just interrogate the perineal for us by ultrasound, and Ray and I will get the Pioneer catheter in. So Vishal, if you could set the ultrasound up, come on the other side and you can do it. And what we're going to do is we're going to just set the Pioneer up. Okay, good. Yep, you can attach the Pioneer needle there. Good, excellent. So, Marichu, what we're doing now is we're going with we're going on the command wire down into the distal SFA segment. And then what we're going to do is we're going to look at the ultrasound to see whether we can identify the area while Dr. Kapoor looks at the perineal. I think is the best target for us. So if he can look at the perineal and sees it properly, because the patient does have some edema because of concomitant venous disease, we will see where we are. So the Pioneer catheter is tracking very nicely for us.
So we get the Pioneer a little closer?
So Pioneer is right here.
Can you give a little bit of slack to him, please?
Yeah, I need a little slack.
Yeah, give me one
For the Pioneer.
Yeah, Pioneer. It's right there. Yeah. Take it down.
Just a little slack. I think, let me just try a few times, Vishal, before we decide.
I'll just scan in the meantime. You keep doing.
Yeah, that's
So
perfect.
we're now getting the Pioneer catheter close. Can you put the IVUS on the screen for them, please? So the problem with this ultrasound, even though it's good, is that it's really going to hurt us because we have a lot of collateralization here. So we need to use kind of both techniques here to figure out where it is. Can you put the IVUS on the screen, guys, for us?
You got to come off, Laura.
Okay. So you can see here, the IVUS shows that at the 12 o'clock position, we should be at the level of the vessel that I want to hit. I'm just going to go ahead and quickly cine. Ready? Inject. So we're going to inject now. So you can see under injection, you can see that we're pointing right at the vessel that we want to hit. I'm probably right there. So my worry is I'm going to hit that collateral or not, but I think I'm going to have to take that little risk. Maybe I can push down slightly and do it, but I think I'm in the right spot here. So also I can see that I have about maybe 3 millimeters that I need to go.
Fielder.
So the Pioneer has a little dial here, so you take it to 3 millimeters. And then what I'm going to do is I'm just going to, under fluoro, just fire. And you can see here that I fired the needle right there. Mag it up for me, Ray, and put it on coronaries. Okay. And you can see here when I cine, so you can see my needle right there. So with that, now I'm going to take my hydrophilic wire, which a lot of people use hydrophilic. Some people use hydrophobic, but I tend to use hydrophilic wires. No curve. It's just, it either goes in or doesn't go in. Some people like to manipulate. I really don't. I just like to put it in, and if it's meant to be, it's meant to be. So we're going to go in forward here with this wire, and let's see how it behaves. And maybe we get lucky and it goes in. And you can see here as we're coming forward, Ray's giving me some wet one. I'm very grateful for him on that one. And notice this has 2 wires, so I still have the anchor wire there, and I can always push this down. So let's see where this goes. Well, that may be too much. So I'm going to pull the needle back a little bit, slightly, maybe about that much. Let's see where it goes now. Seems to be going in a nice area, but am I in the right spot? I don't know. Let's go scene minus here. So scene minus is going to tell me where the catheter was in relation to the Pioneer. Fluoro for me. Show me the one with the Pioneer one that I just took. The one before this. Yeah. Play this one. Nope. The one before this. The one before this. Right. This is the picture I want to play. And you can see. Okay. Well, we're having a little. There it is. This is the one I want. Yeah. So you can see the vessel kind of comes and kind of goes like that. So we might be in the vessel, because we're right next to the other one, see? So now what I'm going to do is I'm just going to ask Ray to take a DSA here, and then let's see where we... Oops, sorry, guys, my mistake. And I hope that we're lucky, like Vishal and I talked about, and we might be okay here. Let's take a nice picture here, Ray. Ready? So we're going to take a shot here, and we may not be lucky. Oops, he's moving a little bit. And you can see here that looks like we're not lucky.
Wow.
So it looks like we're in the collateral next to it, right? He did move quite a bit, though. So let me come back up here. Señor, no mueva, por favor. Okay. That's different, right?
Yeah.
Looks different to me. Let's see. Maybe we're lucky. Inject. Looks like we're good.
Yeah.
Yes, we are.
We're good.
Looks like we're really good there. Let's see whether this goes. And there's our, I think, maybe, God willing. I don't know, Vishal.
No, you were great.
Let's go to another view.
Looks
I mean, this is the hit and miss kind of situation where you have to really take different pictures for you to see where you are. And, certainly looks pretty attractive to us in one view.
And the 80 is
but I don't know which view this is here.
The 80 is coming at 20.
And there's I think we're okay.
Yeah, we're good. Looks gorgeous.
Wow, we're in and out of here. Let's see.
No. I think the way a wire is behaving is...
Yeah, but it might be a collateral. That's the problem. Looks like it may be a collateral here.
If I'm not wrong, I saw the 80 at 20, so, but yeah.
It certainly does look like a PT there.
Yeah.
Okay, let's go to another view here. And again, at home, I just want you guys to understand that it's, it looks can be deceiving. You really want to be smart and make sure you make a decision before you balloon, right? So you can see here, we do seem to be in some collateral, which I don't know what that is, but it does seem to be in a vessel that I'm pretty happy with where we are. But I'm going to check here just to make sure I don't get fooled. Inject again, Ray. The only thing here is, remember, you have another small little segment that behaves that it's the true vessel. See that right there?
Right.
On the front, but we don't know. This could all be an occluded vessel. So I'm going to take this because I'm kind of happy with this. So I'm going to withdraw my needle back. Okay, and then I am going to lock my needle, and then I'm gonna go ahead and fix this, and I'm going to walk this back. So the system is going to come back as a whole. Flora?
Yeah, Flora.
You can walk that other wire back, right? Yep.
Take it out?
This wire is okay.
Okay.
Okay, and then we're just going to walk this out. You can walk that whole wire back for me. So now I'm just walking the Pioneer out. Now I'm going to ask for a coronary microcatheter, guys, for me. Mm-hmm.
Teleport.
That one, guys?
Yeah.
Mm.
I think it's just the curve over the arch that gives you so much.
Can you undo the IVUS
slack?
for me? Can you undo the IVUS for me? The IVUS? Just undo the IVUS. Just unhook this. Yeah.
Bring it closer.
Just unhook it.
Down here.
Yeah, you can just bring it or even bring it closer, I guess. Uh-huh. So, these are some of the challenges we have with these kind of situations.
Good.
You could take
Perfect.
it off.
Okay, very good.
Thank you.
Okay. I'm just going to keep walking, Marichu. I don't want to floor you.
Ready?
Yep.
Yeah. We're good.
You good?
Yeah,
For
you
now.
look out, buddy. Don't worry about it. So we're going to now come back here. So it's very smooth, and hopefully now we're going to go with the teleport catheter. I actually have to undo again, Chu. I apologize. You have to undo the IVUS, guys.
Okay.
You're out?
You have the wire?
Yeah.
Yes.
Okay, he's
Do you
out.
have the wire?
This is the wire.
Take it out. Yep. Now you just have to fix that. And
Wait.
remember, you have two wires there.
You hold it. Mine is
wire is
yeah, I
gone.
got it. No, I just
Just
don't
walk
want to
that
lose
out.
it.
Pull that out. You got the wire?
It's a little bit
Good.
dry. Yeah.
Okay, good. Now give me a teleport catheter. So now we're going to put a teleport catheter, and we're going to check our position before we do anything. Which wire is which now?
The other wires.
The other
Other
wire's
wire's
out.
out.
Yeah.
So now can you protect yourself with some radiation protection, please? So now we're going to go. So obviously Vishal has interrogated the foot if we need to go back in, but I think we should be okay here.
I think at 25.
Yeah,
Down.
I think we should be okay.
Yeah.
Let's see. So that was a nice little demonstration of how to use the Pioneer. The only question you want to be careful about is that you don't want to be through a collateral into the main vessel, which I don't think we are, but you
Why?
never know. Hold on, let me just. Pull
Walk
to
in?
pull,
Sorry.
no, pull to me.
You have the wire? Okay.
Yep. Now fix it, please.
Hold on.
Yeah.
So I'm gonna have Ray. I'm gonna have just advance it slowly. Yep. Go forward, please, and want to take it up to about 20. Go ahead. You got it. Nice rail, guys.
Yeah. 1 second. Right.
Take it all the way to 20.
Yeah, take it all the way to 20. Just about 20 should be good.
Someone said Turnpike or Corsair.
You can use
Either.
either or. Okay, that's good right there, right? A little more, maybe a little more.
Yeah. At 25.
Okay, that's good right there. So we're gonna take it out here. Now I'm gonna ask Marichu for a
3
5 cc syringe or a 3 cc syringe.
Yeah. Right there.
So now we're just gonna go with try to pull back some blood, which I hope we get. And it so far doesn't look encouraging.
Oh, right there.
And now it looks a little encouraging.
Die.
So it looks like we may be okay. And now I'm going to check to see whether we're through.
Die.
So we are now going to decide where we are, and then we'll take a decision on whether we're in a collateral or we're in the main vessel. So again, one of the things, advice I want to give everybody is make sure that
Hallelujah.
you're in the true vessel before you do anything. And here you can see you seem to be in the true vessel. Now remember that Dr. Osman had a beautiful angiogram that showed us that the perineal was the major vessel, and you had a lot of these collateralizations. So you can see there's our perineal. So we're in the robust perineal now, we're through. So now the question is how are we going to navigate this? So I'm going to ask for another command wire, new command wire, and hopefully we can navigate it through. And then we'll take it from here. So
But I think the use of that Pioneer was a very
I mean, like it's a single vessel. We'd like to avoid the pedal if we can, but I don't necessarily know whether we're going to cross this, Vishal, from above. Even though we're through, it looks through. It's a very badly diseased vessel. We still have a lot of work to do here. So,
But I think the good sign is since you were able to get your 035 catheter down, so hopefully we will be able to get it, and the Pioneer device, which is pretty bulky, as you know. So if you're able to get that down with not that relative difficulty. I'm hoping that we should be able to get a definitive therapy down, like DCBs and stenting.
Yeah, but I think
with
the
relatively-
first challenge that we face is getting into that perineal.
Correct.
So we need to get into the main robust vessel to show that we are in the true lumen. You know, sometimes you can have multiple dissection planes that behave, what one please? That behave like this. And then, so let's see. So I'm going in with this. Just going to have OJ just mag up for me at the level of the catheter.
Very smart, Master.
Yeah,
that's
not just mag it up. Yeah,
that's okay. He's fine.
Oh, I see.
let me
That's
get
good.
it
That's good. That's good. I'm glad you did that. See, the thing is, you see that area? It looks like we're in a collateral. It looks like we're not. So let's see. I think it's going to go right into this vessel again. I'm going to have to deal with that little collateral, but who knows? Let's see.
Torque on that wire.
Yeah.
Yeah. Torque. Still not there. Comes. Bada bing, bada boom.
Oh, see, there's a little collateral on top. Oh.
Like right overlapping right on top
Yeah.
of it. You're right, absolutely.
Mm-hmm. Yeah, that's going to be a little bit of a problem here. Let's see.
Maybe.
No, I don't need dye. Let's just see whether we can just manipulate it. So let's pull back a little, right?
Mm-hmm.
Yeah.
Oh, there it is. Nope. Nope. Hmm.
Yep.
Yep. It looks like we got in.
Yeah.
You're
good.
Yep. No, it looks like the perineal. Okay, that definitely looks like the perineal.
Save that. Oh, it's okay.
Yeah.
Okay. Let's do a DSA now, just to make sure.
Sure.
Let's get an IVUS catheter, guys, now.
Regular IVUS.
Regular IVUS.
There you go. Perfect. So now we're in the perineal artery, as everybody
We don't need the
agrees.
Pioneer anymore. So
We don't need the Pioneer anymore. So now we're going to get an 018 IVUS catheter. Or do you want to change out for a Spartacore? Yeah, go down. Let's change out for a Spartacore. So we're going to go down, change out for a Spartacore. Get us a Spartacore. All the way down, right? Mm-hmm. There you go. Now you're in the true vessel, right? So now we're going to take this out. So now that we've gotten through, now we're going to do we're going to give this to Ray for a second. Give me my wire introducer, guys.
Right there.
So one of the things I want to teach everybody, and Vishal and I do this all the time, is you want to create a J loop on the Spartacore, so it doesn't cause any dissections, any perforations. So you just sort of pigtail loop it with your thing, because you're not going to go into any collaterals with this. And the idea is just to leave it safely in the distal vessel. So we're going down now, and then what we're going to do is we're going to do a quick IVUS, and then decide what it is that we're going to do. It's one of those things that's very difficult, because obviously we entered at the level of the distal, what is it called, popliteal / occluded perineal. So now we've got a long wire down, and so now we decide what we're going to do. So Vishal's going to give us the IVUS, and we're going to go through with the IVUS. Walk it out, please. So I'm going to go AP to get the camera out of our way. And now we're going to do a quick IVUS and decide. So any questions, Marichu? Okay, good. So we're going to go with it. The reason, Vishal, why do you IVUS these things?
Well, I mean, multiple factors. Number one is, of course, to determine how the lesion looks, the degree of calcification, the nature of the disease. If there's fibrotic, is calcified, is it mixed plaque? Sizing is very important as well, especially if you're doing DCBs. You want to appropriately size it.
Sure.
And if we want to stent it eventually, so the goal will be try to determine my final therapy. And of course, if you're doing DCBs, if you're looking for dissection planes, if you're intraluminal, not that it's going to change much of that part, but at least knowing any edge dissections at the end of the therapy, if anything needs to be done. So those are certain factors.
So that's a great idea. So you can put the IVUS up, guys, for us. So you can get the angio out of the way and make the IVUS full screen for us. Thank you. That's great. So you can see we're in the IVUS, and you can see that there's we're within the lumen here. Now I'm going to start pulling back slowly. Record, please. Okay, I'm going to start pulling back. And you can see as I come back, you can see there's a lumen right there. You guys agree we're in the lumen, or we're somewhere else?
No, we're in the lumen.
Okay, good. Just didn't hear any enthusiasm from you guys, so I get worried. So you can see there's the lumen right there. You can see there's a dissection, and I don't think we dissected this personally. I just think it's just an occluded, diseased vessel.
Absolutely.
And then over here, we seem to be in the true vessel still, which is very important. And here you can see now we're in a dissection plane.
Yeah.
And that's why we re-entered.
Correct.
And now you can see we're completely, there you go.
Now
Look at the dissection now.
Right.
See, there's two lumens. It's all dissection plane. So we're completely dissected all the way up. Look at that. See where we are? See this flow outside, the flap. So this shows that you're not going to get away without stenting this for sure. So now the question is, what are you going to do to prep the vessel? I didn't see any thrombus, so I don't think there's any reason for us to do a Jedi or anything like that. I think we should balloon it, Vishal. Don't you agree?
No, I agree. I mean,
so give us a 4.0 long balloon, guys. A 4.0 long balloon. Give me an 0.18 BD balloon, a 4.0 BD balloon.
Can you take this off?
So we're going to go. We chose a 4.0 because the distal perineal is quite large.
correct.
So we're going to use a 4.0 to go down. Longest you got?
Yeah.
300. Give me the 300.
Question, is laser an option too?
Right now, I don't know, Vishal, why don't you answer that question? Is laser an option?
So, I mean, not in this case. Laser is usually for if the lesion is very calcified, or especially if you have an ISR and you want to debug the
Vishal?
lesion, that's where the laser comes into picture.
You looked in Vishal's. Vishal, do you have any CO2 cylinders?
I have nothing. He has the CO2. I have nothing. I have the.
You just have the machine, but not the CO cylinders?
No. The machine, whatever was in the box, is
That's
what
all you have? Oh, okay. Tell them to go down to radiology and look for the cylinders.
So yeah, so mainly laser will use it if it's an ISR. That's where it's really indicated, or also if it's a very densely calcified lesion.
Just do a quick diagnostic leg alone, like dilute, dye, quick diagnostic.
And those are the cases where I'll probably take laser as my treatment modality. But in this case, you could see, like PK said, there's a lot of disease, there's a lot of subintimal, not much calcification. Now, the only thing I would probably ask PK is, like, if you have a lot of chronic disease, a lot of fibrosis and all, would you still try to do a directional atherectomy to prepare your vessel a little bit more better, or just directly go for balloon? And
I think
because we're not going to stent
in this case, you're not going to get away without stenting. I think you're very dissected. You're very much, in a situation which is quite bad. So I think in this case, you're going to stent. So I try to save cost here and just go with stenting. If we had thrombus like we thought we may, then I think I would do a Jedi, but here I don't. Let's do a DSA here before we go up. Ready? Inject. So we're just going to see. We want to get to that that perineal, which was very large, and we want to establish flow into that perineal, right? So you figure there we are. So we're in be a little bit lower.
A little bit lower, yeah.
So maybe a little bit lower we need to go. So I'm just going to go all the way down to that 4.0 vessel, which is probably right there.
Just above the collateral.
So we're going to go very slowly. So you can see it's a 300 BD balloon, and I congratulate BD for making such wonderful long balloons for us. So we're going to go up, and you can see here the balloon is expanding, and it's going to be tight in certain areas, which we anticipate it to be. So the worry here is obviously, are we in that collateral? I hope we're not. I don't feel we are, but if we are, we'll deal with it. And so you can see here, we're just opening everything up here, and then we're at 4 atmospheres, and go to, what's nominal here, guys?
6.
Go to 8. Just go to 8 atmospheres, and we're just going to leave it up at 8 atmospheres for now. And I just want all of you to see the length of this balloon. Let's go to low mag here. And you can see it's a 300 millimeter balloon, and it's a 4 millimeter balloon. Good news is patient is not having any pain, nothing like that. And we're pretty much almost at the CTO segment. So it's pretty well expanded. So we learned from the Saval trial and other trials that proper balloon angioplasty really makes a difference. And we know with the SFA studies, especially IMPACT, as well as the Lutonic study and other studies, that this really makes quite a difference in terms of our ability to keep things open. So in the IMPACT, it was obviously the best ever SFA balloon patency. The Viva writing group reported 30% to 40% patency. However, we were able to achieve above 60% at 1 year, even above 70% in certain trials. So therefore, a good balloon angioplasty of a minute, 3 minutes would be ideal. But here we know we're not going to leave it with balloon, so we're just going to expand it nicely and then decide. So we're going to go down here with this.
The vessel size
go down.
Is 4.
4. Vessels are 4. Okay. Well, it's a very diseased vessel.
Yeah.
So what we're going to do is, where was the first? Where was the occlusion? Was it 15 or?
Yes, right above, I think.
Right above 15.
Yeah,
okay.
yeah.
So we're just going to go right above 15 with the balloon. Let me just go above it then. Right, we'll let the balloon come down. Maybe right about there. Let's go up here. Okay. Yes.
What modalities should you not use with such dissections?
That's a great question. Vishal, go to 10.
I mean, especially if you're very subintimal what you are, then probably an orbital atherectomy devices you would want to avoid because the chances of perforation through the adventitia go higher up, especially in CTOs. They're technically not recommended. They're actually contraindicated. Lasers, you can use a directional atherectomy. Again, with caution, you can use them.
Yep.
But other than that, mainly orbital atherectomy is not advised to use. If
I agree. I mean, directional atherectomy, you have to be careful. Orbital atherectomy, you have to be careful. So therefore, I think that in these kind of conditions, especially now, with not a heavily calcified vessel prep is not an unreasonable thing to do with just a balloon angioplasty, and then decide what you want to do. So what I'm going to do here is we're going to come down with this balloon. And what I'm going to do is just pull it back into my sheath, and then after it comes down and just take a quick DSA,
Right.
and hopefully we have a nice picture, and then take it from there and see how it looks. So there's our balloon is taking its time to come down, so we'll give you the old coronary double negative. And then even though we dissect it, we dilute the dye, it tends to take its time to come down. So, in this situation, Vishal, I mean, if we didn't work out with the Pioneer, we clearly would have done dual access,
Right.
and other things. So we will, I think the Pioneer worked out well for us. So we're just going to walk this out. And, if he had a perforation or God forbid anything like that, then we know that, he'd have pain, he'd be bothered at this stage, but he doesn't. DSA?
Mm-hmm.
So just hopefully we see everything is good.
Yep.
We don't have any issues. So we'll see some flow, I hope, and no perf. And then we'll be very happy. And there's our flow.
Wow.
And there we don't have any perf. So that certainly does look very good.
Beautiful.
And I just want to look down below to make sure that everything looks as good down here as it looks above. So now the question is, what are we going to do and how are we going to deal with it? We have to deal with that, which we will. So the question now is, how are we going to treat this? So we also have a proximal stenosis, Vishal, and the question is, with this looking the way it's looking, would you go with just a DCB and then leave it, with the DCB alone?
Well, I mean, my goal is to try to layer it up with the drug. So what I would do is probably use long DCBs to do the DCB of the entire
So
segment.
you'd like to leave nothing behind, just to do a long DCB?
With a spot stenting, a spot stenting if need be. I mean, like you say, in the popliteal segment, it looked a little bit trashed out. So if you could do a short supera or any of those nitinol self-expanding non-drug coated stents in sections. Otherwise, I think if the DCB gives a good result, then and we just follow the patient, especially he's a clottic, and we just follow the patient closely, and then
you don't have to stent across the pop.
Right.
So let's break it up into segments. Let's talk about the different DCB choices. Obviously, you have a lot of different choices. You have some with longer data, some with less data, and the issue here is what DCB would you choose? And also you have 014 system, 035 system, and and that's the question as well. So if you look at the distal here, you have that distal right there, that spot. So we know that could be a 4050 vessel. You want to put a 40 DCB across the pop and then a 60 from the pop up, or how do you want to work it? Or do you want to IVUS it and decide? But I think IVUS is going to give you the wrong vessel size because we're very dissected.
Well, in that case, I would probably, if I have to, I'll just put a stent in there. I don't know if you want to infra-pop. Again, the thought process is infra-popliteal, below the knee vessels, DCB approval, not approval, off-label use. When we talked about, trials being held. So in this case, we could do a DCB if you want, or we can just put a short 4-5 stent.
Yeah.
Because there's a dominant perineal vessel,
Well, you could treat it as a pop rather than a perineal and just say the whole thing is a pop.
Then we can do a 4-0 DCB.
And then we can put a 4-0 DCB across the pop, or do you want to do a 5-0? I think we can do a 5-0. Give us a 5-0 150 impact, guys.
Yeah. We can do
yes.
In the distal pop.
Well, should some of these long CTO be staged? Staged for what is the question? I mean, I'm a firm believer, and it's going to be kind of funny, and Marichu's heard it a million times.
150.
Either you poop or you get off the pot. If you're on the pot, it's time to poop. And you're on the pot, you started the case. So we need to finish. So should it be staged? If it's staged, if you have multi-level disease, I think it should be staged. If you have, you also have to have a good indication to say why you're going below the knee in a claudican. If you have an ulcer gangrene patient, then obviously you don't want to do that. You'd rather do everything in one shot to to restore blood flow. So in a claudican, you should not. I mean, you're not going to do the proximal SFA and then stage the distal SFA. You're going to do the SFA. And in this case, you had an occluded pop into the perineal, so you kind of have to do everything in one setting. Correct. That's my firm belief. Yeah. So that's where I am with that, Vishal. I don't know about you.
No, I think I agree with PK 100%. I mean, we know we've been taught to fix the inflow first and then go after the outflow. But in this case, the only outflow really is the perineal. So I think we definitely have. Hold on 1 second. Let me see where the wire.
Oh, geez.
Yeah. 1 second. Okay, go. Mm-hmm. So in this case, because only perineal is the outflow vessel, I definitely want to give him the full advantage of getting a flow down all the way to his foot, especially being only the pure vessel, dominant vessel supplying. So in this case, I definitely agree with PK. Yeah, we crossed.
Oh, we crossed it?
Yeah, we did.
Too far then.
Yeah, you have to pull back.
I'm going to come back.
There, you're right at the collateral.
Okay, good. Yeah. Go up here.
So definitely in this case, we like he said, treat perineal dominant as pretty much like a distal pop and do what's right for the patient. So I think I agree with the plan perfectly.
Yep. So we're just going to go up slowly here.
That 3,
Nice.
3, 4,
4, I have 4,
5, 6.
5, 6.
Okay.
Timer.
So now we have a long segment, popliteal 50, 150. I think it's a good size. So we're going to leave this up for 3 minutes as for the SFA balloon. I'm sorry, the Lord? No, the Lord. Okay, good. Okay, so we're just going to go up here and just going to make sure that part expands, and it does. So now we need to get a 300 balloon here. And this is the question. Do we go with the Lutonics? Do we go with a 60250 impact? What do you want to do, Vishal, and how do you decide? I mean,
again, like you've talked about multiple times, and like from the data and the trial, personally, the longest data we have is on impact, 5 years. So if we go by the impact data, which what we believe in the longevity of any trial, then probably we go with the impact Medtronic. Lutonics has a 1 year, maybe 2 year data, which is not officially released, but even though they come up with longer.
Yeah, I mean, they've done a great job of giving us DCBs that are long.
Correct. And also go through 5 systems.
And we have a robust 1 year data with Lutonics. So, I always struggle with that as well. And here, you have about what? You have about a 3, we said, he said 15 to, 15 to what? How long is this lesion here? Let's see. So we're going to have to go actually probably 13, right?
Yeah.
13.
So 13 all the way down to...
Probably 2. 13 to 30 is 170.
The 250 or 300?
It should be a 300. 300 should cover all.
Or what you could do is you could say I'm going to stent the proximal with a drug-eluting stent. Yeah. Whether it's a balloon assisted supera stenting or do it with a Zilver PTX, which we could talk about. So why don't we do this here? How long has this balloon been up, guys? Do you know?
It's almost 2 minutes.
Almost 2 minutes, another minute more. Yeah. So get us a 60250 impact balloon. Yes.
What blood pressure do you target in such cases or does it not matter?
Well, I mean, you don't want the patient to be very hypertensive. Naturally, they are going to be hypertensive to a certain degree, despite sedation, because you are stretching their vessels, so on and so forth. So therefore, I think that the idea here would be is, anywhere from 150 to 200 is probably reasonable systolic pressure during the procedure, because it's going to fluctuate quite a bit when the balloon is up and when the balloon is down. Okay. Yeah, that's a good question. I think we're going to talk about that in a second, Mary Chua, but I think absolutely the patient needs to be on long-term antiplatelet agents. I think he needs to be on probably an antithrombotic without any data right now to suggest it. So I think right now we'll just go ahead and do antiplatelet agents with Plavix and aspirin for 3 months, and then maybe we do Xarelto if the data comes out solid for that. If the guidelines come out, the data is solid, but the guidelines come out. So now we're going to go ahead and switch for the Impact 250 balloon. So of course, this is a 035 balloon, which is going to make it very difficult to take it out of the body. And the part of the reason why we talked about the lutonics there, but we are going to, and also the length, it is only a 250 length in this particular balloon. So now we're going to go in with this balloon here. Okay. And obviously we're not going to pull the wire back because we're in that plane. We got to be very careful. Yep. So we're going to go forward, probably till about 11, right? We said
11.
So we're going to go to about 11, and then we're going to decide what to do proximally. Oh, boy, just barely made it.
The last hinge, I
think that's good.
Yeah.
So it's another 3 minutes of watching paint dry here. So he may have pain here, obviously. So we're going to go up with this.
Discharge in the morning?
Yes, if everything looks okay, absolutely.
That was a question.
Yep.
Another question is primary patency versus TLR. Is one more important than another?
Excellent question. Whoever's asking these questions is a man after or a woman after my own heart. The TLR I think is a very soft endpoint. I think we need to look at primary patency as a hard endpoint for these patients. As we know, claudicants, you want to reduce repeat revascularization. You want to go ahead and also keep them with symptom-free survival. TLR is very subjective. I mean, I think if we have objective evidence of reduction in TLR, I think that's fine. If not, majority of the time, it's very subjective based on the operator. And I think that's going to be the issue that we have to be very, very careful about. That's going to be the issue that we have to be careful about. But so in an ideal world, primary patency probably would be the best thing for us. Vishal, your thoughts?
No, I think I completely agree with you. I mean, based on all the trials and the primary endpoints, primary patency is what essentially is noted into. Of course, TLR is what makes a difference most of the times between a surgical aspect of a trial and an endovascular aspect. But like what PK said, it's a very soft endpoint. But primary patency, I think, should be the main driver for us to look into whether we select a procedure, a device, or any other things. But if you look at this PK expansion, what do you think about the variable expansion in this case?
Yeah,
so I think it was very subintimal in this place, or is there recoil?
I think that you got to think about it. Our paper and Jack says that 30% residual stenosis is clearly the reason for target lesion failure. So we might have to think about maybe expanding this and putting a Supera stent across this up to 15. We also published a paper recently in JAVIT that's going to be published. Oh no, actually, I'm sorry, that's in JAMA Cardiology. Excuse me. Yeah. No. Scientific reports, JAMA scientific reports that looks at the use of DCB with Supera, clearly showing that DCB reduces the TLR rates in Supera, even if they're elongated, and pretty much makes it equal to nominally deployed Supera. So we have a lot of options here to decide. So I do agree with Vishal, and I think that's a great point. The expansion of your balloon has to be looked at prior to doing it. So now we're pretty clear that we want a spot stent between 30 and 25. And probably between 20 all the way up to 15. Yeah. So I'm not going to leave a gap, so we might as well just put one long stent and decide. So let's walk this out now. So this one I'm going to fix the sheet, and as Dr. Kapoor comes down, we're just going to look at the distal wire, make sure the wire doesn't come back, and that's it. And just walk it out. So we're just fixing this as the balloon comes out. There's a lot of resistance in this balloon as it comes out through the sheet. Okay, very good. So now we're going to look at a DSA shot here. This is probably a good picture.
Yep.
So hopefully everything looks okay. So that's the area we're concerned with. We talked about, is that 30% residual? I think it's a question that we can talk about in a second. Do we leave it and follow it and then decide as things go on what we do? But that needs to be treated. So the question is, do we do a short DCB and put a Supera in? That may not be a bad idea, But then we also have the proximal lesion. Show me the proximal lesion earlier, my friend.
Go forward.
We also have the proximal inflow lesion to deal with. So Osman, what do you want to do here? I mean, what would you do? I mean, you're graduating. what thoughts would you do in your practice next month?
Yeah,
when
I
you're in
think
practice?
that proximal SFA near the ostium, I think you probably have to stent all the way back up, pretty close to the ostium of the SFA.
So you would take care of that with a stent, not a DCB?
Yeah, I think I would put a Zilver up there,
Okay.
most likely.
All right, and then the rest you would leave, sort of secure your inflow, and then leave the rest.
Yeah, follow up with ultrasounds. I think we do every 3 months with the ultrasound, 1 month after, and then every 3 months.
Okay. So I think that's reasonable. I mean, why not? So if you look at these lesions, I know this type of lesion hasn't been studied in the trials. In the impact trial, if you just take that lesion, and even Lutonix, that's the perfect lesion for that trial. They would do it, and that lesion would be left alone with the DCB. So the other argument is if you go C minus times 4, and go to the last picture we just took. Yep, this one right here. And nope, one more. Yep, this one. You see that? So the other argument is, should we do another DCB here, or should we just do a Zilver PTX here and then post-dilate this, secure our inflow, and then go ahead and do a short DCB up top? That's another question. Vishal, your thoughts?
I think I'll agree with that. I would probably.
You want to do the Zilver here?
Yeah.
Okay, guys. So give us a Zilver PTX here. I think we're all in agreement. So it's a 6.0. I'll tell you right now.
70140.
70140. Sorry, 70140. 6:15. Okay.
Yeah.
Okay. So I thought we had a lot of time, so we were taking time. Okay, no problem. So now we're going to stent this segment. Okay, no problem. We will take care of it. So we're going to go ahead and stent this, and then we'll take a final shot, and we'll finish offline. So now we're going to put a 7.0 stent here and cover this proximal really dissected zone that we saw, 70140. So we're using a Zilver because Sapara doesn't have a drug on it, and I think it's reasonable here to use a Zilver and then post-dilate the Zilver. And then maybe offline we fix the proximal lesion, and we're done with the case. So the Zilver PTX is going in here. And obviously you can use a Zilver, you can use a Sapara, just different, I guess, folks or different strokes for different folks. Yes?
What would be the chances of restenosis instead of a long CTO?
I think the chances of restenosis are significantly there. If you look at the impact long studied lesions greater than 250 millimeters, and in that the TLR rates were low with impact, but a 40% provisional stent rate, which is what we're kind of dealing with here. So yeah, I mean, I think the TLR rates are are reduced with DCB, but I think it's hard to say what is your restenosis rate by PSV. I would assume that it's going to be higher, but your TLR rates are low. So it's a question of whether you're a TLR person or a PSV person, and we take it from there.
Come back.
Where's the end of the stent?
Oh, so right now it's at 24, and the proximal is at 11.
Okay, that's good, right?
Yeah,
you like that?
It covers.
Yeah, go for it. Yep. So we're just going to deploy this here at this point. Vishal is just going to deploy it. We're going to have to post-dilate this, obviously. So give us his 7015 Viatrack, please. Actually, you know what? Don't give me that. Give me a 70018 Bard BD balloon. Okay, 70100 is fine. So we're just going to go ahead and balloon this out, and then we'll take a final picture and we'll sign out, and then we will we'll see you next time. Yep. So I'm just going to show you the stent expansion. You're going to see how that stent is not expanded well, and how we're going to have to expand it now post. So we did balloon it with a 6.0 with quite high pressure, and there's been quite a bit of recoil, and I think we did the right thing here by stenting this. So we're going with the 70100 balloon, and then we're just going to go ahead and balloon this open, and we'll be done. Okay, ready? Mm-hmm. Rail?
Yep.
Modification is highly recommended.
I think there's no question. I think we've done that with this patient. He has been under our care and under one of our referrings care. He's on all the appropriate medical therapy. He has undergone exercise therapy. But with this lesion, I think everybody would agree that exercise therapy is probably not going to work, which it didn't on his case. So therefore, I think, I think this guy's done pretty much what he could do.
6.
So we're going to expand this now to 10, 12. Just try to expand it open to 14 if you can. Really open it up. You can see a lot of fibrosis at that area.
Yeah.
Okay, good.
14.
Okay, good. All right, wonderful.
Fluorescence.
So that's expanded nicely down. So we got a little bit of recoil as expected, but not a lot. And we'll hit that offline with a high pressure short balloon. Go up here. And now we're going to hit this part here as we talked about. Again, expand this nicely. Very nice. Get down.
14.
And then we're going to go down a little bit and hit that part as well. And get everything done. Go there. Okay, 14 atmospheres. There you go. 16. Okay, down. Good. All right, so we're done with this, and now we're just going to take a couple of pictures, and I think we'll show you a very nice result of a pretty difficult case that we were able to do within the hour. Ready?
Yep.
So we're just going to walk this out. And then offline, we'll fix the proximal lesion. It's not a difficult lesion to fix. So you guys saw how to cross these lesions with dissection entry, switching to and you see that the need of pedal access is not a lot. You don't need it. If you have good techniques from up and over, you certainly can do whatever you need to do to cross these lesions from up and over. As you just saw in our hands, mine and Vishal's, you saw what we did. So I just want to show you a nice lesion here. So the popliteal is open, the SFA is open, great flow, a little bit of recoil there. We'll deal with that in a second offline. And then we just want to make sure that there's no perforations. And the foot shot certainly shows that everything looks good. You can see here great flow in the thing. You can see a wonderful perineal, which looks like an SFA. And then at the level of the foot, you're going to see that the foot is going to look really, really good. Let me just open up the blinds here and then go a little cranial for you to see the bottom of the foot. Oh, yeah, there you go. Okay.
Don't move.
So you can see here, there's your foot shot. So everything comes in, the arch fills, and he looks pretty good. So with that, guys, we thank you. We thank everyone and our team at MedStream for doing such a great job. And I think we'll sign off to Cybele in California. We have as good weather as well as he does over there, so we can't be jealous of him. But we'll finish up the rest of it offline. So thank you again. We'll see you soon. Bye-bye.
Thank you.